some of the slides, looked at escalation of behaviors, and then kind of talk about some things that you guys can do when you see patients in your setting at the front end as you're kind of receiving people. You'll see them at various stages of escalation, and maybe how do you de-escalate that, how do you work through that behavior. And this is just the basic training objectives for OSHA. First of all, what is workplace violence? Physical assault would be one thing that would be relatively obvious. We have our fair share of assaults in the ER, and we've, over the last several years, have worked on developing a safety committee to address this. Every time there is an assault in the emergency department, there's an occurrence format that we encourage staff to utilize, telling them that they don't, just because they work in a high-risk area doesn't mean they have to tolerate physical assaults. There has been debates in the legislature and some different outcomes recently around the designation of what do you categorize as physical assault and what is the consequence of assaulting a healthcare worker. So there has been much debate around should it be a misdemeanor, should it be a felony, and currently it is my understanding that assault of a healthcare worker is now felony class. Certainly we're happy about that because we can certainly tell patients at the get-go when they're threatening physical violence, we can explain to them if it is appropriate what the outcome would be. One of our physicians just last week had this very discussion with the patient and said, this will not go well for you, sir. You need to think about what you're about to do. So physical assault would be one aspect. Threatening behavior is probably maybe even more common. This would be that person who maybe hasn't said that they're going to kill you, but they certainly have said, I will sue you. You're going to be talking to my attorney. If you don't back off, something bad may happen. So it's not, the threat is real, it is tangible, but it might not be of a homicidal nature. Verbal abuse, this is extremely common with people who are not feeling well, who maybe are intoxicated, or who have maybe an altered mental status. They are certainly saying things that, in the old days we'd say, you have to wash your mouth out with soap. Our staff pretty much get pummeled daily with verbal abuse, and they're learning to detach from that. I think it's important to just stop right here for a second and explain that there's different dynamics going on. At least in the old Freudian model, there are two concepts of how a patient might see you, and primarily that's a transference mechanism. They see you as the representation or the embodiment of someone in their life. Okay? So let me give an example. Security usually triggers a lot of patients adversely because of the uniform, right? They haven't even seen the patient before. They just come in, they're doing their patient watch, and the patient's immediately getting agitated. And if you probe a little further, the patient will say, well, he's a cop, right? Or he reminds me of a cop, and I hate cops. So really, the security officer didn't do anything to stimulate that response other than to look like or create within the patient an unconscious kind of dynamic that's going on around this animosity that they have for police. All right? The flip side would be how you respond to the patient. Maybe the patient is triggering you in some way. We would call that countertransference. Okay? So it's important for you, this would be the concept that I want you to get. As a provider, as a ReConnect staff, as someone who's providing assistance to a patient, if you begin to feel like you're getting a little bit agitated, a little bit tense, right? That something's not sitting well with you. The patient's just triggering, pushing your buttons, okay? You might want to ask yourself, where is this coming from? Because in the end, examining and dealing with countertransference can help you be a better provider, can help you be a better assistant and helper to the patient. So we, staff, continually go through analysis of their own issues. Okay, sometimes it's just a matter of, I had one nurse tell me, that lady is driving me crazy. And we sat down and talked about it a little bit. She looked and sounded just like her mother. The nurse had issues with her mom, and all of a sudden this patient is just going on. And I kept saying, what is the deal? I understand she's a little needy, but what's happening here? And it came out that it was, the woman sounds just like my mom, over and over and over again, I can't take it. So that's countertransference. And does that make sense, guys? We have to be aware of what we bring to the table anytime we're interacting with somebody else. So from a psychological perspective, being aware that they are going to react to you, you are going to react to them, and to just keep those dynamics in play. And the verbal abuse is just a great way to look at that, because they're going to start maybe saying things to you that were completely unprovoked, and it could be because of a transference mechanism. And then harassment. This would be more defined as a behavior that's ongoing around something that's uncomfortable. They are beginning to, it's all of these types of things taken to a different level with it could be continuous phone calls, it could be continuous threats that you're being bombarded with as a staff person. A lot of times it's difficult for patients to disengage. Once they've kind of latched onto you emotionally, sometimes they will either find it to be an incredibly positive relationship or a relatively negative relationship, and the harassment would, I literally had a lot of patients continue to contact me long after they've been discharged to continue to try to threaten different lawsuits and or action that they were going to take against myself, against the hospital. Certainly, when we look at harassment, we think of a sexual nature. I did have some patients stalk me before and threaten certain things around that. So hopefully you don't have to deal with that on the front end in ReConnect. But just to be aware that there's different types of violence, from the assault to the threats to the different verbal abuse, and then even the harassment level. A little pop quiz for you. Violence is the leading cause of death on the job. True or false? Don't cheat. That would be false. The leading cause of death on the job is motor vehicle accidents. And the second leading cause is violence, both in the nation and in California, where this primary study came out of. Okay? Second one, homicide is the leading cause of death for women in the workplace. What do you think? How many think true? Yeah, handful. Okay. It is true. Yeah, might surprise you. Disputes, true or false? Disputes between workers and supervisors are the main motive for workplace homicides. What do you think? True or false? That would be, workplace homicides are accounted for largely by robbery. Okay. And 75% of the victims were shot in those instances. Okay. Anybody want to take a guess as to how many workers are murdered on the job each year in the United States? A lot. According to the Department of Labor, 5,524 fatalities in the workplace, 609 were due to homicide. It's a pretty salient statistic. You can see here from this pie chart that the breakdown of different workplace fatalities in California, this is at least a decade old. But you can see that the majority are transportation, equipment related, violence related, 20% being in that category for violence, and the rest related to exposure, falls, and fire. And out of 478 fatalities, 96 were due to violent episodes. How many people each year are victims of non-fatal assaults on the job each year? Anybody want to hazard a guess?
5,000.
Okay. Check it out. Try to soak that in for a second. These are some other statistics that you can look at in terms of non-fatal assaults by occupation, police, retail, medical, teaching, mental health professionals, and transportation. So here's the OSHA's 3 types of workplace violence. Violence by strangers to commit robbery would be the Violence by customers, clients, or patients. Number 2, that would be the category that we're most interested in. And violence by employees and supervisors would be the third. Workplace homicides, again in California in 2002, the largest being robberies, second, clients and customers, and then third, worker manager. So in that order of the previous listing, 60, 30, and 10% respectively. A risk factor is any condition that increases a worker's risk for violence. So what are some of the examples of the risk factors on your job? These would be some of the major ones. Working alone or in small numbers. Obviously you're isolated and at higher risk. Working late night or early morning. What's the what are the shifts for ReConnect at this point? At least theoretically, when would you be having workers?
Right now, they're typically here from anywhere from 8:30 to 10 in the morning until the equivalent period, 4 or 5 hours, in some cases 6 hours later,
Gotcha.
So till 2 in the afternoon.
In the ER, obviously we don't close. So there's a lot of, at night sometimes there are increased risk factors with people going to different parts of the parking lot to up there on the hill. And that's why security is asked a lot of times to escort staff out, especially if there's been an interaction. We've actually had patients say, I'm going to wait for you after you get off. And they will. They will sit there and wait all day for the staff to get off shift and then harass them as they're trying to go to their car. Also a higher risk factor. Well, if the folks that work with money are a little bit higher risk, because once people find out that they have the cash on hand, as you've seen, robberies account for a lot of different assaults and workplace violence with theft and robbery. Delivering passengers, goods, and services, also another high-risk group. Having a mobile workplace like a taxi cab or police car, working in high crime areas, guarding property or possessions, or any contact with the public is considered a risk factor. So how can violence be prevented on the job? One, if you are working late or alone, try to avoid that if at all possible. Some people have no choice in the matter because that is their shift. But we recommend cohorting, buddying up with somebody, especially if you're going to be isolated, calling for a security escort if you're working late, carrying your cell phone, redesigning your workspace to prevent entrapment, training staff in ways to diffuse violence. We're going to get to some of those techniques in just a little bit here. Placing the curved mirrors in hallway intersections, maintaining good lighting, and preparing a plan for customers who act out. We do have a code green policy. I don't know if you guys have read through that, but essentially a code green is any kind of situation where there's a security assist needed, out of control patient or family member. Sometimes we call code greens on as many family members as we do patients, and that is simply because the family overreacts to a circumstance that they can't quite comprehend. Maybe there's their family member or loved one is not doing well medically, and they can't, they're thinking that the staff is not doing enough for them. So they get agitated, they get threatening. Remember that patients on the medical floors do not get screened through the metal detectors in the ER. They can come up straight up to the floors. They could be carrying a firearm, they could be drunk, they could be completely inappropriate to be in the hospital. And we don't do, that is where we lack, I think, from a hospital setting. We don't have a way to screen those people appropriately, and we've had people pull firearms on us upstairs. And security then responds, and we're all like, okay, now, how are we going to deal with this situation? In the ED, it's great. We are safe because nobody's coming into that ED. It's a controlled environment. Okay, so we talked about that, redesigning your workplace and having a controlled setting. We have that in the ER, not so much on the medical floor. So as a safety committee, we are looking at ways to increase security and monitoring of patients that may come through, or staff, primarily visitors that come through our hospital setting, to make sure that they're safe and appropriate. So we're working a lot with the medical floors. Our team is working with them to train them to recognize people that may seem out of sorts, seem threatening. I'll tell you another one that we get a lot, and you may not, may go without saying, but gang involvement. We have patients that get shot in the field, they come in, they're on ICU level. We have to immediately change their name for their safety. and then be aware of any kind of visitors. Try to block all visitors if at all possible for that patient. And if they come in and inquire, make sure that we have security backup just to be sure, because these gangs would stop at nothing sometimes to eliminate a competing gang member. And if they know they're already vulnerable, that they didn't die in the shootout that they had off of Colfax, they're gonna try to find out where they are. Okay, so it's a little unnerving to think that could happen, but it is the reality of the nature of what we do. So controlling access to employee work areas is critical as well. And in the ED we have that in spades. It's not so much on the medical floors. Any other thoughts about prevention strategies? And do you have did you decide? I know before we were talking, we weren't sure where the guys were going to be working and where their pods would be or where their workspace would be. Did we figure that out? Did you guys?
Yes, we worked with the emergency department leadership and one of the nurses, and we have a whole plan for triaging which patients are going to get a ReConnect coach. And it involves either referral from a nurse who's doing callbacks or from the patient self-identifying from a list of choices about the primary issue for them, follow-up care with a doctor, transportation needs, other kinds of resources that they will identify.
Great. And we just hope that we can carve out a space. In the ER, there's just so much, as you know, so much drama going on. We've got levels, we've got trauma, we've got a lot of people moving in and out. So hopefully your workspace you'll deem it to be safe for yourselves, and we'll have to look at it going forward as you have more contact with patient care to see, is this an appropriate setting for us?
And it's primarily in an area they call Pod 3 in the emergency department, which is primarily ambulatory patients, people who walk into the emergency department seeking treatment. It's furthest away from the area Brandon was describing where the secure rooms are. It's furthest away from areas that could be potential trouble or disruption by patients.
One thing that we do, and they were all due this past weekend, and that's why, is computer-based training. Are you guys familiar with that concept too? Learn modules. We do a lot of training there. There's a lot of clinical modules. There's a lot of refresher courses around infection control, patient safety, emergency preparedness. For some of the nurses, there's different line starts and control measures, point of care, things like that. And one of them was restraint of patients and responding to violent episodes. So we put that in play and mandate that staff can't even work until they've done one of those computer modules. And then myself and others are assisting and rotating through validations annually and even twice a year to provide this type of training so that we increase insight and awareness around workplace violence. Responding to a violent incident, number one is to isolate and secure the work area. You want to make sure that you really get at, if the patient is really out of control, there's different stages of escalation, and we'll talk about that in a minute. But if it's if it's past that threshold limit, where this person is not going to be talked down, they are not going to, if they're kind of at that sort of early anxious level, where they're just kind of pacing, right, wringing their hands, and they're just upset, and you engage them at that point with your compassion, with your empathy, with your reflective listening. What's happening, Mr. Smith? It looks like you're very upset. You get them to talk it out. Then they can increase to another level of defensiveness, where they're becoming more hostile. I don't need your help. You get away from me. Begin to start threatening. The acting out patient would be someone who's now crossed the line and is now physically out of control. You would want to get away from that situation. That's really it. We don't want you to be in danger at that point. You want to get out, and then you want to see if you can, with security's help, isolate and contain the work area. Call 911 if necessary. Obviously in an ED we don't need to do that. We have our own components, but we do have a Lakewood Police substation that is in the main ED. Did you guys know that? So we can have access to Lakewood PD pretty fast if we needed to. Seek medical attention for any victims that may occur, and report the incident immediately to your supervisor or shop steward. You want to file an incident report? Again, I'm on my staff constantly about this. A lot of times they'll get hit, scratched, poked, bitten, things like that, and they'll say, well, I really wasn't injured that badly, so I didn't want to do that. No, 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 no. I don't want to hear that. I want you to fill out an incident report every single time. That protects you, okay, long term from any kind of aftermath. If something should happen to you later, we have that on file. A lot of times if there's exposure, bites are considered that as well, where the skin is broken. Maybe you get assaulted significantly. One of the first years on the job in the Psych ED, when it first opened up, I was trapped with a antisocial guy who had put 3 police out in the hospital. Found out later his rap sheet was very thick. He punched both of the nurses, incapacitated them, and then was wrestling with me for a good 10 minutes before anybody could get back there. He hit me with an IV pole, threw every piece of furniture that he had at me, and the door stuck. So when the staff tried to come in and help me, the door jammed and they couldn't get in. So, yeah, it's thank goodness for adrenaline, right? My staff members and colleagues still tease me. They said, I've never seen anybody move that fast before. I said, you were dodging, you know. he was bigger than me, and he was just laughing. He was swinging punches, and I was dodging them all and trying to block and move. Hopefully that never happens to you. But in the Psych ED, we're kind of locked in back there. And that's probably the more dangerous piece. While it's controlled access in and out, imagine if everything goes wrong, now you're stuck back here. And so then I remember in slow motion as I'm dodging him, looking over and seeing all these faces looking at me through the window, and they were pulling on the door like, you know, looking, oh look, there's Brandon. And so in the end, we do want the incident reports to be filed, because then we can track from a QA perspective, from a safety perspective, what led up to this incident. How can we do things better in the future? What can we learn about this incident to protect you, to protect Centura Health and St. Anthony Hospital? So we definitely want you to file that incident report. And I know it's laborious and whatnot in medicine, but definitely important to do. If psychological trauma occurs, we use a lot of employee assistance programs for the post-counseling, and we suggest that anytime you've been the victim of an assault or a violent outburst, and then you give the referral to the EAP. 5 warning signs of escalating behavior. First would be sort of maybe a confused person, not really sure what's going on in their environment. They're just out of sorts. We'd say technically they have an altered mental status. They're just not tracking well, and they may even be speaking in terms that reflect that confusion. You're trying to get intake information from them, you're trying to get basics, and they can't give it to you. They're all over the place. They have what we call maybe tangential thinking. They're kind of going in one direction, then they go this way, and then kind of like a stair step. They're on for a second, then they're on, off. They don't know, they're not oriented to who they are, where they are, the date, what's happening with them. And they might even be speaking in terms of information that's extremely out of date. We have a lot of patients, especially with our geriatric population, that may be talking like it's 20, 30 years ago, and they're talking about it like it's present day. So a notable level of confusion there. Frustration, we know what this is, right? This is sort of when patients are not getting their needs met, they don't feel like they're being heard, they are, you know, one of the biggest indicators of satisfaction in the ED is door-to-doc time, so how fast they get in the door to when they see the doc. So for our HCAP scores and things like that, they go really up when we decrease the amount of time that they have to wait. So it's all about perception, right? Patients come in, they want to be seen immediately. They don't have to wait. They don't have to go into a room. So one of the things that if you see what we've done in Pod 3 that David was talking about is the quick registration. Patient comes in, they have a minor complaint. They have a sore throat. Okay? They can go in, they can make that quick left turn, hit Pod 3. They have a provider in there within a matter of 10 minutes or less. They've got their script. Boom, they take a right. They're right there by financial to check out, and they're out the door. That's a great patient experience. I got in, I got seen, I got out. That's what I want. They don't want to be moved from one area to another, like a holding area, and then just sit there for about an hour, and then, then someone comes in and talks to them. Okay, it's going to be another while. that increases patients' frustration. And this is what can lead to eventual acting out behavior because the person is not aware of what's happening. They're looking at their watch. What's going on? Why is it taking so long? So one of the things we talked about before with a lot of our staff trainings was acknowledge the patient, introduce yourself, describe what is happening with the whole scenario. Mrs. Smith, you're here for to get some lab work done. I understand that you might have an infection. We're going to run some lab tests. We'll be back in, give or take 10, 15 minutes to touch base with you, explain the procedure, and then thank them for it. So as you go through that entire model, the patient is completely aware of what's happening. And what we find is if you can kind of collaborate with them and say, I'll be back in 15 minutes, I'll be back in 30 minutes, then they at least have something to count on, right? And so with our area, a lot of times they can see us in that psych nurses station because there's clear glasses, plexiglass, that they can see us. And so I tell my staff, you got to be on your best behavior, right? Because they're watching you, and if you look like you're goofing off, even if you're not, they're going to take that poorly because they're in a position that they don't like. And if you're back there eating or kind of laughing it up with someone, I said, imagine what they interpret that as. They don't know that you're not laughing at them. They don't know that you're not just taking a break and not doing your job. They have no idea. So that increases patient frustration. So I would say long wait times are one of the biggest complaints that we get in the ED in terms of patient dissatisfaction. I didn't get to see someone fast enough. I was in pain. I wanted that provider to be right there. And thankfully, if you look at the records, we've been off the charts in the ED, right? Over 95% patient satisfaction for the last several months. We are doing a bang-up job. They don't poll our patients, okay? Because for the most part, their experience was not as pleasant as the main ED. They're psychotic. They're thinking we're out to get them. So they leave off our patients in the overall ER HCAP scores. But we are still, nonetheless, we are still doing we're working hard with the main emergency department to improve our quality of experience. I round as much as possible back there to get feedback from patients. What's it like for you? Acknowledge their experience. That's a huge thing for you guys, right? To decrease frustration. Acknowledge that they're having this frustration, and then they know that they've been hurt. Blame is a huge one as well. That's your fault. That was the one you mentioned. I'm unhappy. It's all your fault. This is going to cost me a lot of money, right? And you're making my bill go up by keeping me longer. Anger and hostility, those are just continuing to escalate further along sort of a continuum of a person getting ready to act out. The frustration is completely out of control now, and they are almost enraged, and then that becomes more hostile behavior that can lead to the threats and the physical acting out. Warning signs of confusion is the person appears bewildered or distracted, like I was mentioning before. They're unsure of or uncertain of the next course of action. They really don't know what to do next, and they're kind of looking to us to explain what that should be. So how do we respond to a person who is confused? Listen attentively. Somebody said that before. I listen to them. One of the things we talk a lot about in listening is it is an active process where you can reflect back what they're saying. Mr. Smith, it sounds like you're very upset. I am very upset. They'll begin to agree with you. Once you've hit it right, you're going to know it because they're going to either agree with you or disagree. Ask clarifying questions. What exactly is it that I can do for you today? Give factual information. Okay? This lab test is going to take probably a half an hour. We're going to need to know the results before we can proceed. That at least gives them something to go on around what's going to happen next and helps de-escalate the confused patient. Questions on confusion, maybe how to handle that. Can be quite difficult if the person is so out of it that they can't understand what you're saying. So you need to discern quickly how much capability does this person have to have a logical conversation with me, or am I just kind of making things worse by trying to over-explain? The extremely confused patient is not going to be able to digest it. And so you're better off maybe trying to refer to a nurse or to another clinician that can assess the level of confusion and maybe provide some interventions quickly in terms of medication or other collateral support. Warning signs of frustration. The person is impatient and reactive. This is the type of person who begins to pace in the room. You can tell just by their behavior. They are not sitting still. They are not happy, and they're beginning to get, their fuse is getting a little short. The person resists the information that you're giving them. I don't care that you said it takes 30 minutes. That's unacceptable. I have to get to work. What kind of place is this? The person may try to bait you, okay? Patients sometimes are so desperate to get what they want that maybe they're going to try to draw you in and get you on their side. Maybe they're going to try to split you against another staff person, right? I like you. You're my favorite. You know that, right? I hate that other guy, that nurse that came in, but I like you. You're my favorite. And patients will do that all the time, and then if you don't recognize it quickly, you will have such great discord in the department because they'll only ask for her every time. No, she's my favorite. I told you, get out of here. I want her. And so then it's like the staff is kind of like, what do we do with this? No, you don't allow that to happen. You set consistent rules. I'm your staff today, period. She's not here right now. You're going to have to deal with me. Responses to frustration. Move the person to a quiet location if at all possible, and I hope that with that pod that you've got an area that is confidential, of course, and is quiet, because I think that can help people be less frustrated. Imagine if you thought everybody else was overhearing what you were saying. It doesn't, not only is it not appropriate for HIPAA, it's disconcerting to any of us if we feel like we're trying to tell you private information and everybody else can hear it. It's why we have the white noise back on the psyche. Reassure them and talk to them in a calm voice. I think a lot of times it is all about cadence of speech, the gentleness of, if I respond to a patient like this, right, the tone of my voice can be incredibly calming. Also, the nature of my hands. If I do this to a paranoid patient, what are they going to think? I've got something behind me. What are you looking behind your back? Show me your hands. So if I put my hands like this, they can see them, right? How about this? What does this convey?
I'm not interested.
Yeah, maybe an authoritative position. I'm over you. You know, obviously, if you walk in and you're just like, yeah, hold on. You know, I mean, it shows disinterest, right? And we see this a lot. So, cadence of speech, the volume of your speech is intrinsic into, I'm here for you, I'm not a threat to you. Show them your hands, okay? I tell people this all the time, even if they're not clinicians. I just say, let them see your hands because they don't know that you're not, I mean, even this is not safe necessarily because if someone were to attack me, what am I going to do? You know, so you keep your hands up, right? And I know this is not physical takedown skills 101, but if you have your hands like this, right, you're a little bit better able to, one, make them feel more comfortable, and then if they were to lurch at you, you could block, okay? I would not stand like this with someone who's agitated. Why? I'm really, one, I'm open to attack, but I also can't, you know, I can't move out of the way. So just, you know, I mean, again, we're not going to do the physical stuff, but if you just put one foot slightly behind the other, right? I mean, you're not doing this, but you're just kind of, you're able to then move back, right? If someone were to lunge at you. I also would not, I can think of times where maybe they're going to talk to someone. Don't ever let the patient get between you and your exit, okay? Always keep the exit open. You stand by the door. Don't ever let them block your way out. So if you're in a pod, don't go around the desk or whatever and have them in front of your exit. Just don't do that. That's a setup. Because if the patient gets outraged, now you're trapped, okay? I don't know if you guys have any panic buttons. We carry these little fobs around with us with a big button on them, and it will sound the air raid siren. That's what it sounds like. And everybody and their brother will come back to help us. Okay, so I don't know if you'll have any panic alarms or anything that you need to do that, but really try to keep yourself in terms of your posture, your tone of voice, in a way that would keep a person de-escalated, but never, ever let a patient get between you and an exit. or your only exit. If there's multiple exits, that's no problem, but does that make sense? I mean, you absolutely want to keep that in play. You want to know where your exit is, and you don't want them to block your way. You want to attempt to clarify their concerns. So what I'm understanding from you, Mr. Smith, is that you're in a hurry today, and you don't understand why this pain has been occurring over the last 2 weeks. I mean, you really want to repeat back some of the things that they've said to you so that they know that you've been listening well, if you've been attentive, and you're clarifying their concerns. So you need us to expedite this treatment today so that you can get to work at 3 p.m. Warning signs of blame. The person places responsibility on everyone else. You gotta love that graphic there. It's everyone else's problem. It's not my fault. Patient may accuse you or hold you responsible. Yeah, because you're in a position that represents part of the healthcare system. You're a part of this group that seems to be oppressing them. And they're finding fault with others, obviously. They may place the blame on you in particular. And you're just maybe one of the first sources of contact that they have after maybe being registered. So how do we respond to the blaming? We disengage with the patient and bring in a second party into discussion. Great thing to do. Grab a nurse, grab a care tech, grab a security officer, grab someone who can be there to witness what is happening and provide extra support. Use a teamwork approach as you do so. And you know, obviously having more than one person there can be safer for you, but you want to explain why that person is here. This is Sally. She's here to make sure that I get everything correct about what you're saying. We're just trying to make sure that we understand exactly what you need and how to help you. You want to draw the person back to the facts of the situation and get off that sort of power struggle with the blame. You know, no one wins with that in terms of whose fault it is. You want to just draw them back to, we need to get back to your lab test, Mr. Smith. That is the reason that you came in, yes, to check out why you're having this pain. You want to show respect and concern, of course, compassionately, empathetically, and focus on areas of agreement to help resolve the situation. I understand that you are in pain, okay? Pain management is the 5th vital sign, as they say now. It is so incredibly important in terms of treating patients. We see a lot of people acting out simply because they're not comfortable. Understand that that can always be a reason, especially in the ER, of why they're not being cooperative, why they're being so irritable. They may be in physical distress or emotional distress and pain, and you want to make sure that you address that and say, okay, I understand, we're going to get you that, have that nurse come in and assess that now for you. Warning signs of anger. The person may show a visible change in body posture. They're going to be flexing muscles, being tense. They may even start, right? We see this happen a lot. Sometimes property is, they take it out on the physical property of the room or of the desk, and they're demonstrating that they're getting angry in that way. Pounding fist, pointing fingers, shouting, screaming, also warning signs of anger. This is a very risky behavior, anger, okay? So our responses to anger would be not to argue. Okay, again, as I said, don't get into that power struggle. It is not a good idea. You're not going to win it. And you can even just say that. I don't want to argue with you, sir. I just want to help. I'm going to try to get some other people in on this so that we can address this a little bit more aggressively. When we talk about not offering solutions, people generally try to offer what they can't back up. So just be realistic with your goals. And if you can, in fact, bring someone in to address it sooner, do so. Don't make a promise that you can't keep, because now you've lost all trust with the patient. They will not believe you anymore. And so if you are going to offer a remedy, I would say you want to make sure it's something that's within your power to do. Okay, so rather than not offer solutions at all, I don't know that I agree with that as so much as it's got to be realistic and within your power. Does that make sense? You've got to be able to say, well, that's not something I can help you with. However, I do know the person to link you with to get this solved. You want to prepare to evacuate the area or isolate the person if necessary. This would not be something that we necessarily want you to have to orchestrate, but you just need to know the steps that you can utilize to get security involved if you need to. And you want to contact, as I said, security or your supervisor. What are the warning signs of hostility? Physical actions or threats that appear imminent. There's immediate danger of physical harm or property damage, and the out-of-control behavior signals the person has crossed the line. How do you respond to the hostile patient? We disengage and evacuate the area. That is one. Your safety is top priority here, okay? We would not want you to try to engage with that patient that's in the hostile state. Isolate the person if it can be done safely. Alert supervisor and contact security. When we engage in, when adrenaline kicks in, we have the fight or flight response, right? This is to protect us. Obviously saved my life that day with that guy because being by myself for that long, I mean, it was several minutes, seemed like an eternity, but it was probably only about 10 minutes. All things considered, it saved my life. So when we have different reactions, the first reaction in trauma is to kind of freeze, right? A lot of us kind of have that sort of paralysis that happens. And that's, in nature, we see that all the time. Playing possum saves the animal's life. The predator is coming at them, they play dead. Okay, that's no longer interesting, I'm gonna move on. There's sort of a hypervigilance that comes after that, after sort of that initial paralysis, where we are more aware than ever of what's going on in our environment. And then we kind of come down after that to more of a social re-engagement phase where we're actually more with it. So what we find is when we're exposed to violence, most of us are going to have maybe a release of some serotonin and norepinephrine. We're going to be activated, and it's going to increase our response time, okay? Our strength is going to be a little bit, I mean, our muscles are going to be tensed and ready and primed and ready to go, ready to move, or ready to fight. And so it's important to be aware of those dynamics. Ways to, if you were the unproductive aspect of fear would be that you can overreact or have an inappropriate response in addition to being paralyzed. But, as we said before, the positives would be that your strength and speed are increased, that your sensory acuity is increased, and that your reaction time is a lot more decreased. Again, they still said, man, I've never seen anybody move that fast in my life. Guy was hurling chairs, I mean, he literally was taking objects and like taking this and throwing it at me, and I'm having to block and move and grab it and pull it away. Good thing, adrenaline. Ways to control your fear and anxiety, or understand what makes you afraid. What kinds of situation would produce fear in you. Learn techniques to protect yourself in a crisis. Use a team approach. Don't do this solo. If at all possible, you're part of a bigger team in the ER, right? We can help each other. All we need to know is that you need help. And learn physical interventions to manage the acting out individual. What you want to do with any of these is to remain calm, okay? You want to isolate the situation. You want to listen. We talked about that a good bit. Limits that you set on people at some of these earlier stages before they're in the acting out just need to have a limit that is set with them so they understand what they can and can't do. Young people test this all the time, right? Kids are going to want to know how far they can push you before you're going to be able to react and answer them. So the limits should be clear and simple, they should be reasonable, and they should be enforceable, okay? They've got to be simple. You can't give them complex instructions that they can't possibly process. They've got to be reasonable. They've got to be something that the person can actually do, and then they've got to be something that you can back up. As I said, don't ever offer solutions that you can't actually meet, because then you've destroyed the trust. Questions on that? A lot of this has to do with proximity. Can I have a volunteer? Anyway.
Come on.
Stand over there and face me.
No, thank you.
Okay, tell me when you get uncomfortable.
Now.
Oh, okay. You notice her bubble is quite large. In other cultures, it is appropriate to stand closer. You can stand right in front of someone, and that's okay. I mean, that's considered disrespectful. In Western cultures, about 3 feet, you know, yours was maybe a little 3.5 feet. Our proxemic bubble is, you know, we're safe here. You need to stay out of my grill. You gotta stay out of my face and don't violate my personal space. I've actually had people not know what we were doing when we had that exercise, and some of them get almost way too close, and they're like, whoa, 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 that is way too close. You were standing too close. You need to back up. Okay, so a lot of your interactions with patients can be diffused just by keeping a respectful proxemic distance from them. Okay, it is uncomfortable to have someone right in your face. So I don't know how far are they when clients are coming or patients are coming in. Are they sitting across a desk? Are they sitting? What kind of?
No, they're walking into an inpatient setting, into an inpatient room.
Okay.
And initiating conversation.
Gotcha. So then it is up to you how close you get to the patient, or how close you get to the patient. So proxemics, keep that in mind. Distance to the patient. What your stance is like. Again, maybe nothing that's off that would keep you out of balance. Don't stand over the patient if at all possible. I think eye level, if you can sit down with them and be eye to eye, that's much less threatening than me standing over you. This again is arms akimbo is something that is, while natural, and I think a lot of people do it, probably not the best with a patient because they feel that power differential. The speech and the cadence of your voice, how fast you're talking really, really fast and they can't even possibly defy you. That's anxiety. Nice flow to your speech. They want to be able to hear you, okay, so you need to project but not be yelling at the same time. And then just your intonation, your inflections in your speech. This is an interesting little piece. How about this sentence, I didn't say you were stupid. Now, watch as I put inflections on different words. I didn't say you were stupid. What does that convey?
Others do.
Others do. I didn't say you were stupid. How about that? Yeah. I didn't say you were stupid. Right? Just think about the different emphasis on each word. Same sentence, said 3 different ways, makes a lot of difference when you put the inflection on different words. So keep in mind that. It's very simple things that we probably take for granted every day, but are very important. Yes?
What is the emergency department's plan for when a gang fight breaks out? And you have only one cop?
So the question was, what is the emergency department response for a gang fight? We'd call a code green immediately. We'd hit an activation, and everybody that's been trained in it, which is really all ED staff plus support personnel, would respond to that immediately. And yes, someone would call if it was with firearms or dangerous weapons. Police would be called immediately. So we'd call it code green. Overhead, it would be announced overhead. You dial 55, code green in the location. They'd say code green, ER now, or room 15, psych ED, wherever. Yeah, we would call it code green. And so it'd be broadcast over the entire hospital, and you'd have staff ready to respond immediately. Now, with those types of situations, again, remember, we're contained in the ED. It's more likely, I don't know I'd say more likely, but it's harder to track on the med-surg floors, where the person comes up and then brandishes a gun that we weren't able to track because there's no metal detector. That would be more of the issue, I think, because if they come through the emergency department, they're going to go through that metal detector. Yeah, absolutely. Security will not even let them through to visit without a pat-down, without a screen. Other questions that you have? Yes?
Could you tell us what a typical scenario would be like? Would we be going into a cubby cubicle thing, wherever what would be a typical scenario?
I think from what you're saying, David, though, the question is what would be a typical scenario for the ReConnect staff to go into with the patient? They're going into the patient room, yes?
Yes.
Okay, so you go into the patient's room, and in the medical rooms, there's a gurney in there with a lot of medical equipment. They may or may not be attached to said equipment, IVs, oxygen tubing, things like that. But definitely you have the ability to stay with the door here. You come in and the patient is bedded here. So I would definitely make sure that you keep awareness of where that door is. And as your colleague said, don't turn your back to the patient. I mean, obviously if they're way away, you could probably do that safely and get out, but I would not, especially with an agitated patient, never turn your back. And you could just back out, watching them at all times. So patient room would be the answer to that. I don't think you would ever probably come back to the psych ED though that's not necessarily the case. We were discussing situations where if they've been there for a bit and they're lacking a primary care physician, happens all the time, you guys might be the people that we want to discuss how to refer them to a primary care physician as they exit. So it is not impossible, but we also have social workers to assist with that. And you would always be, there would always be plenty of us around if you were to come back to the site.
Who decides when a sitter is appropriate for an inpatient?
Excellent question. Who decides when a sitter is appropriate for an inpatient? That would be the team lead, the charge nurse, along with consultation with myself and Dr. Richter. A lot of times the physician obviously can order that if they feel like the patient is dangerous or needs a line of sight type situation where if the person were to look away and they would fall, they would have imminent self-injury, they're suicidal and can't contract for safety, maybe they're medically compromised. We have a lot of sitters for patients that are confused, delirious, geriatric, and demented because they can't remember what's happening. So from any moment, they might kind of come to and realize they've got all these tubes everywhere and they just think, well, I don't need that. I'm just going to pull all this stuff off me. And then that puts them at risk for harm. Not because they mean to hurt themselves, they just don't know what they're doing. So that would be treating physician or consulting physician, team lead, Dr. Richter, or one of my team can recommend sitters and things like that. If they're under an M1 72-hour hold, have to have a sitter no matter what. You can have a sitter without them being on a hold, but if they're under a 72-hour observation for emergent mental health treatment, have to have a sitter.
Are the sitters part of your team, or
No.
are they just specially trained?
No, they come out of they're carved out of each budget for the individual unit. And also one of the reasons why I've said we need a psych unit back, because 480 hours of a sitter population on one floor just last week, 480 hours of sitter pay, someone there basically 24/7. And I'm saying, hey, you're racking up some bucks here. Wouldn't it be nice to have an area where you didn't have to have those sitters? Yeah, bring back psych. Bring back a psych unit.
The things you're talking about are kind of scary, and I'm sure there are lots of people sitting out here going, I'm never going to go into the ER if that's what it's
Right.
like. But realistically,
Sure.
how likely is it that something bad is going
It's a
to
small
happen
percentage.
in our?
It is
our
a small
presence?
percentage of all the ED patients that we see. In fact, the question is how this is scary stuff that we're talking about, and how often would this likely happen? I think I don't know if I could give you an exact percentage, but really, statistically speaking, the average mental health person is only 2% likely to engage in violent behavior. That's statistically no different than anybody else in the population.
And I just
So-
assume that the medical staff would be
Yeah.
protecting us
Absolutely.
by who they would allow us
Right.
to see.
Assessing
and who they would
risk.
Sure.
not.
And I think that's things that Beth and David and I have talked about. We just need to screen well. If the person's unstable, it's not an appropriate request to have a ReConnect coach go in the first place. So I think it's more to help you understand if things went poorly very quickly, would you have some just basic understanding of what to do, to notify a supervisor, to make sure you got out of the room quickly. Their security is great, and they float through that ED all the time. And they're always moving around and checking on folks, and they check on us all the time. In fact, David, I was talking to Porter, and they have what's called ED Safe. It's a system that goes through the entire ED department where there's a little light bulb that sticks down from the ceiling, and they can activate different color levels to demonstrate what's the acuity of the department at the time. Green is we're safe, yellow is we've got some escalating people, and red is it's on. Like there's some gang activity or somebody that's hostile and in restraints and seclusion, that kind of thing. So HSS, the security, the broker service for security actually came up with that, and they have that at Porter, and I was touring through there just last week looking at maybe instituting that for our department so security can be on a higher level alert to help you, to help us, to help the whole department. In general, didn't mean to frighten you by this, but the fact of the matter is you're probably never going to be asked to go into a situation if the person is deemed to be anywhere near not with it aggressive, hostile, psychotic, intoxicated. It just doesn't make sense for a ReConnect coach to be going into a situation like that. So, yeah. Okay, any other questions? That's all I have. Thank you for your time.
Sure. So let me just add a little context to this. So first of all, it's never happened in 4 years that I've been affiliated with this program. There's never been any kind of an incident, and I think Rita, who's been here longer than any of us, can attest to that as well. So the second thing is knowing the signs of escalating challenges and knowing how to respond to those is useful in any context, whether there's a potential for physical violence or just verbal abuse or anger or blaming. So this is designed to provide some ways of recognizing that and how to handle it. And the other point I wanted to make is whether you're in the emergency department or on the inpatient floors, the case managers are still making a determination of who's coachable and who they assign us to. And I think that is working well, as evidenced by the fact that there hasn't been any kind of this kind of incident for a ReConnect coach since its inception. So, and the final thing I want to say is, for those of you that aspire to coach in the emergency department, there is a slightly increased chance of that because you're in that environment. And so I wanted you all to have a realistic sense of that environment, even though the likelihood of an incident remains low in that environment. And where we've positioned ReConnect and the way it will work in the emergency department, it's almost equally unlikely to be an issue in that environment. But you may see things there, as opposed to being in that situation yourself, you may observe things that may be unsettling. And so this is also designed to prepare you for what you might see in that environment. Yes, Linda?
I just make a quick comment. I worked in the ED department for about 5 months, and part of that was through the holidays around Christmas, where you would expect a lot of activity, and there was. One point is the hospital has expectations for quick movement through that ED. So if they think somebody's going to become inpatient, they want to make that assessment and get them up to the floors. And with all of that activity, they don't want us interacting with the nurses. The nurses need to be taking care of the patients. So we work with case management, and you're tied to the hip. They teach you, they want you to be independent, but again, there's a time element to get the patients out. There are very specific cases that are just not appropriate for coaching. And so you're not going to get something that's always high speed and you've got all this activity going on. It's not like TV, folks.
Yeah.
And the one piece is that they don't want you going into the secured area. I just can't imagine that there would ever be that. The one thing that I would say, and it's true, the security is there. You're really safe in there. The one thing that I would caution is that there are a lot of highly emotional situations. So, we've heard people just regular lay coaching on the different floors saying, I don't have the emotional strength to do this, I'm out of here. You see a lot, I saw, and even, and as an example, it was the evening of Christmas Day when I was in ED. All of the rooms were full. We had 3 chaplains there. There was one gentleman who had tried to commit suicide, and he was very in critical condition. Now, you don't see this person. That is not anything that you'd ever see. I saw them bringing in another person that was bleeding, but again, and another woman who was badly beaten. But the minute those kinds of things come in, you have all these doctors and all these nurses going in and around. That patient is their focus. And your number one rule is to get out of the way. So you're not gonna be up there looking at the patients, you're not going to be seeing her. Your number one rule is to stay out of the way, and then rely on that case manager to say, there's a patient over there that needs a PCP or something of that nature. So you're not gonna get into the thick of the things, you just need to stay out of the way. The caution is, there are some pretty sad circumstances that bring people into ED, and you need to decide whether or not that's something that you can handle. And you're not gonna get slammed with it, you just need to know that you're gonna hear those conversations, you're gonna be aware that that kind of activity is taking place, and you just need to decide, is that something that you can deal with? People are really highly key, and I'll tell you, the chaplains and the case managers may have that high intensity, are generally the ones that are there. We're not trained for that kind of a thing. A gentleman came in, he had a heart attack, and he was doing well by the time I met him. And his question to me, I asked him if his PCP knew he was here, and he said no, that his doctor had just retired and they needed a new one. Well, there was my role. But in the ED, it isn't, in fact, your involvement is gonna probably be less than it is on any of the other floors, simply because of the nature of the circumstances.
There's so many layers of treatment opportunity. We're gonna make sure that that patient is getting everything they need in the emergent context first, before you guys would ever be involved. So that's a good point.
And then another thing though, that is if they're taken to another floor, if they're admitted, then you would go with the patient, and I did that, and their family members were there. And then as they get them settled into the patient room, you don't wanna leave them there, and then have to look for another coach. So that would be a good way that you could coach them, be with them, and then hand them off to the coach that is delegated to that floor. But it isn't nothing like the TV shows.
It's not like TV, and that's the bottom line. So if we ever do, if we ever coach in the emergency department, when we coach in the emergency department in the fall, there will be more training around exactly how that's going to work. This is more generalized training you can use anywhere in the hospital as a coach. It's useful for that purpose. And so how this will actually work in practice, we will spend the time talking about that for those of you that are interested in that opportunity. Okay. Any other questions for Brandon while he's here? All right.
This is also, for the just daily living. I mean,
Yes.
we live in a
Good
violent
point.
world.
Good
And
point.
we try to help people understand that these kind of principles will serve you well no matter what. I've been involved in altercations outside of the hospital, just going home. I was pumping gas the other day, and the guy was out of control and drunk and was hostile. I thought, okay, here we go, I'm on the clock again. Here we go. So it's like, how do you intervene at that point or make sure that you're safe? So following these things, I think, can be very helpful to you. Thank you again for your time.
So where are you buying gas?